So would you like to start? Because what is happening is the people, students will keep on joining, otherwise.
Okay.
So I'll just introduce. Well, good afternoon, study group, and welcome to the last day of the course on therapeutic nutrition. Today we have for you 4 lectures on nutritional management in the ICU, refeeding syndrome, lifestyle modifications for obesity, metabolic syndrome, and preserving nutritional status during radiotherapy and chemotherapy. So, and then this will be followed by tests, which will be conducted over a period of 30 minutes. So over to the first lecture, that is nutritional management in ICU by none other than Professor Afzal Azim. Sir, over to you.
So, is it visible now?
Yes, sir. Yes, sir.
Okay. So I'm audible also.
Yes, sir. Yes, sir.
Okay. So very good afternoon to all of you. And I'll be discussing over the next 30 odd minutes, about something about nutrition in ICU settings. Now, you all know that ICU is one scenario where patients who suffer from any acute illness or any organ failures, they are the patients who get admitted to ICU. And a nutrition in them is a very special type of a nutrition, which needs some special concerns for them. So I'll just try to discuss them. Clinical nutrition has been undervalued. Malnutrition the reasons are that it has been observed that malnutrition in ICU patients critically ill can range from as high as 50 to 78%. But ICU usually has a very heterogeneous population, and it has not been external validated, like what should be the nutritional requirement for a particular cohort of patients. Even the effect of nutrition on outcome, it's very difficult to correlate that what difference in outcome has been made by a good nutrition or a poor nutrition, because the patients who are admitted in ICU, they are suffering from multiple illnesses and comorbidities, and anything else may be contributing more to the overall outcome. Studies as far as some specific aspects of nutritional therapy are concerned, they are usually conducted like patients that ICU studies may be on proteins, they may be on carbohydrates, they may be on immunonutrition, antioxidants, vitamins. But as a holistic approach to nutrition, the studies are very limited. And most of the studies which are available for critically ill population are usually small and they are underpowered. Now, if you look at the ESPEN guidelines, now I'll stick to the guidelines. There are 2 guidelines usually we get from the European Society and from the American Society. There is hardly any major difference between the 2 guidelines. And these guidelines, they keep on updating them, reviewing the evidence and literature which comes during that intervening period. And they are the guidelines which are best for the clinicians at the bedside. Now, you have to understand the term guidelines. Guidelines means that they may help you, they may assess you in majority of the patients, but it doesn't mean that you have to follow the 100% guidelines for each and every patient. You may have to customize, you may have to modify them from patient to patient. And especially this is more useful and it sounds more good, especially for ICU patients. This is just to show you that how the guidelines, they evolved. So the first guidelines, they came somewhere in 2006, then 2010, 12, 13. They tried to incorporate the studies of whatever evidence came during that period. They tried to incorporate some special population of patients, and then they keep on revising the guidelines. Now, this is the third round went in 2005, 15, and 18, and the latest guidelines which are available to us are of 2019, and I'll stick to these guidelines. So whatever I'm going to discuss in the next few slides, that will be based on the PICO and the recommendations. PICO stands for population, intervention, control, and outcome. So there will be some specific questions regarding the ICU patients. Who should benefit from medical nutrition? Now, medical nutrition is a word which includes both enteral and parenteral nutrition. And who should be considered for medical nutrition? Now, to understand this, we need to understand the phases of acute illness. There is an acute phase which lasts for a period of, say, 1 to 2 days. This is followed by a late period of acute phase, which may last anywhere from 3 to 7 days. And then either or sometimes the patient may land up in chronic phase of illness and continue with catabolism. So you have to understand the stage of the patient. Now, this is just a very theoretical approach to the acute illness. The acute phase, which is described as an early period of 1 to 2 days, may extend for even 3 to 5 days. And similarly, the anabolic phase or the late phase may not start after 7 days, exactly after 7 days. So you have to tailor your therapy according to it. It is just to give you an idea that medical nutrition, which includes both antral and parenteral, is extremely important for these patients with acute illness. And it should be considered for any patient who gets an ICU admission for more than 48 hours. And there's strong 100% agreement among all the societies and groups. How to assess malnutrition? Now, there is no gold standard, especially for ICU patients or those patients who are at risk of developing malnutrition during the ICU stage. Weight, lab tools, muscle mass, the different scores, the Nutric score, the ICU score, whatever score you use, they're all controversial and they have not been validated as such in ICU settings. The golden rule is, the bottom line is that general clinical assessment, and you should assess what is the degree of malnutrition of the patient. Screen your patient for malnutrition. One thing which you have to understand and you have to emphasize is that any patient who is critically ill and who is staying in ICU for more than 48 hours is at risk for malnutrition. So that means you have to think of malnutrition for the patient, irrespective of whatever scores or assessment you have done. Now, there are some grades and severity of malnutrition which has been recommended by the guidelines for ICU patients, and they're based on like the phenotypic criteria and the etiology. And here you will see that there are only 2 stages which have been described for ICU patients. One is the moderate malnutrition, the other is the severe malnutrition. So there is no like class of mild malnutrition. So any patient who comes to ICU stays for more than 48 hours he's predisposed either to moderate or severe malnutrition. And then you have to take the history of weight loss. You have to look at the body mass index, the muscle mass, if possible. You have to look at what has been the food intake. What has been the food intake, the malabsorption, and what has been the disease burden. With what disease burden the patient has been admitted to your ICU. So when should nutrition therapy be initiated and which route should be used? Now, this is an extremely important question which comes to the mind of every clinician who is dealing with ICU patients. So as I told you before, that beyond 48 hours of ICU stay, nutrition becomes a real concern for the clinician. Now, early enteral nutrition is if it is started less than 48 hours. But whenever you start before in the first 48 hours, then you have to be very, like you cannot be the full nutrition which the patient demands. You have to be either on the hypocaloric side, or you have to just start with 30% or 40% of the nutrition requirements. And then you need to gradually build up over a period of days. And the recommendations are that by 5th or 7th day, you should be in a position to provide the complete nutrition intake of the patient. And especially in the first 48-72 hours, we should try to avoid overfeeding of these patients. Now, this is just to show you that whether it should be a bolus feed or it should be a continuous feed. Now, you must have observed, if somebody of you have visited the ICUs or working in ICUs, that usually the food, the nutrition for the patients is based on enteral diet, and it is given every 3 hourly or 4 hourly, depending upon like what is the acceptance of the patient. But then there are some recommendations that why not to go for continuous feeds at the rate of say 40 ml per hour or 80 ml per hour, 60 ml per hour, and then you meet the daily need requirements of the patient. Now, if you look into the evidence, what is the evidence in favor of like continuous versus bolus feed, you will find that the continuous enteral feeds only favor in one area, and that is that less incidence of diarrhea. As far as the other outcomes of patients are concerned, the infections, the overall length of stay, the outcome, there is no benefit of continuous enteral nutrition over the intermittent enteral nutrition. Now, again, the route. whether it is pyloric or post-pyloric or nasogastric, and does it influence the outcome parameters of any patient? Now, you must have seen that the most common route which is tried in almost any patient is that we always try first to go for nasogastric feeds. And this is what is recommended even for ICU patients. But if these patients, they have intolerance, or the patients are predisposed to high risk of aspiration, like they are not able to protect their airways, they are like on multiple organ failures, they are on high mechanical ventilatory support, they have got some neurological deficits, then you might think of going for post-pyloric feeds. Now, when we talk about the post-pyloric feeds, there is no clear-cut recommendation that we should go for nasojejunal or we should go for nasoduodenal feeds. So what of the most of the time what we are doing is that in ICU settings, whenever we talk about the post-pyloric feeds, we mean it is the nasojejunal feeds. It can be done either in the radiology suite, it can be done in the bedside, or sometimes in some difficult patients, this route is also adopted through an endoscopic measure. There's a meta-analysis of almost 16 studies which has shown that compared the post-pyloric versus the gastric, post-pyloric and the pre-pyloric feeds, and they found that there is no difference in mortality. 11 studies showed no difference in mortality. 7 studies showed no difference in diarrhea or the ICU length of stay. Intolerance was more with gastric feeds, but it did not influence the overall outcome and the behavior of the patient during the ICU stay. Less VAP was noted with post-pyloric, but even if the incidence of VAP was less in the post-pyloric feeds given to the patient, but they had no effect on the overall length of stay or days of mechanical ventilation. So even if the VAP is less, but it does not affect the overall outcome. So you can prefer nasogastric, and in some population, subset of population, you can go for post-pyloric feeds. Now, does the administration of prokinetics improve the outcome, or should they be routinely prescribed for all patients? So the answer is that this should not become a routine prescription. But yes, if you're having if you're encountering that the gastric residual volume is high, the patient is giving you high RT aspirates, you can think of using prokinetics. Now, if you go by the ESPEN guidelines, they suggest that erythromycin is the first line, but it varies from continent to continent and from different ICU settings. The first drug of choice for prokinetics, most of the places, is metoclopramide. And then if you're not able to achieve your nutrition goals in 48 to 72 hours with metoclopramide, you may think of adding erythromycin. Now, whenever you use metoclopramide or you're thinking of using erythromycin as a prokinetic agent, the first thing which you have to do in such a patient is that you have to rule out any mechanical obstruction. So if there is an absence of mechanical obstruction which you have ruled out by clinical or by ultrasonography, then you can think of using the prokinetics in the form of metoclopramide or erythromycin. Now, they have got some complications also. If you give too much of metoclopramide, you may land up with extrapyramidal syndrome, you may land up with QT prolongation. And even it has been found that one of the concern for the intensivists regarding the prolonged usage of erythromycin is that it may even contribute all to the microbiota of the patient and contribute to more infections and add to the resistance. And how to define like what is my energy expenditure for my patient. So whatever predictive equations are available for rest of the patients, they do not apply at all to ICU patients. The gold standard for ICU patients is indirect calorimetry, but it is, if you go into the literature and you try to review the evidence, you'll find that indirect calorimetry has been used mainly for the research process, and it has still not become a routine practice in ICU settings. If indirect calorimetry is not available, there are some other ways of identifying the equations for the energy expenditure in the form of oxygen consumption and the carbon dioxide production, like using the PA catheter or etc. And then you calculate the resting energy expenditure for your patient by multiplying the carbon dioxide production by the factor of 8.19. But this is more or less of theoretical, and ultimately you have to go based on your clinical judgment. Again, when you start the nutrition, should it be isocaloric, should it be hypocaloric, or you should overfeed your patients? Now, the recommendations are absolutely clear that it should be hypocaloric in the initial phase, and then you can step up and you can go up to the complete requirement of the patient of 80 to 100% over a period of 5 to 7 days. So you should not be in a hurry to achieve the energy expenditure of the patient, and your calories should be met in a very gradual or a stepped up manner. This is just to show you that isocaloric diet that improves the short-term mortality. But it has no difference on the long-term mortality, infection, or the length of stay. And there is a study known as the EAT and IC studies, which were goal-directed nutrition therapy versus the standard therapy. And they found that there was no advantage or harm as far as the outcome is concerned, the functional outcome, the morbidity, or the mortality. So it means that the rule is very simple for ICU patients. Initially, it can be hypocaloric and try to become isocaloric. And there is no use of hyperfeeding your patients going for hypercaloric feeding. Only thing is that you have to be gradual and you have to achieve your targets over a period of 5 to 7 days. Now, what should be the protein intake? It is believed that these patients who suffer from critical illness, they suffer from they have reduced levels of albumin. This is also known as hypoalbuminemia of acute illness. They lose their proteins very fast. And what we need is that we do not want that this patient should suffer from muscle breakdown. Because if they start losing their muscles, then they land up with critical illness, neuropathy and myopathy, neuromuscular weakness, and it becomes a very difficult patient to wean off from the ventilation and from the life support therapies. Now, what is the evidence for the protein supplements? The evidence is that anything, if you go by the figures of 1.2, 1.3, 1.5. So a simple way to remember is that my patient should get somewhere between 1 to 1.5 grams per kg per day. And then depending upon what is the urine, what is the PUN, what is the urinary output, whether it's a renal replacement therapy, what is the tolerance, you can modify your proteins according to the patient. But there is no benefit of giving a very high protein delivery to the patient. Even if you talk about the randomized control trials on high protein versus low protein, they're also very less. They're not also conclusive, and they have not found any mortality benefit or improvement in secondary outcomes. But one thing is for sure, we do not want protein catabolism. We do not want the patients to lose their muscle mass. So you have to achieve your protein intake. Again, as I said, by 5th or 7th day, you should try to achieve whatever protein targets you have for your patient, which may range anywhere from 1.2 to 1.5 grams per kg body weight per day. Now, the other combinations of carbohydrates and fat. So the other components of the nutrition, other than the proteins, is the carbohydrates and fat. And it is recommended that the glucose should not exceed more than 450 grams per day. But I think so this is slightly on the higher side, which has been recommended by the guidelines. Most of the patients, they suffice with around 200 grams, 150 to 200 grams of glucose per day. And then the rest of the calories, they have to come from the lipids, even though the recommendations on the lipids are that the total lipid content to meet the caloric need on a daily basis should not exceed 1.5 grams per day. And there's a very strong consensus for this recommendation as far as the lipids is concerned. But then again, you have to see that what type of patient you're dealing with. If he's a patient of respiratory failure type 2, it's excessive carbon dioxide production, he's suffering repeated episodes of hyperglycemia, he has got enhanced lipogenesis, then the modifications can take place in both the carbohydrate and the fat content. Even though there are not some great evidence of based on what type of fats you are supplementing, there are some expert recommendations which suggest that the medium chain triglycerides, monounsaturated fatty acids, and polyunsaturated fatty acids, they may be used in special group of populations to supply the energy needs. Glutamine, yes, when it was introduced in 90s and early 2000, it was like almost every patient in ICU was getting glutamine as an immunonutrition. And it has been found that over a period of studies, over a period of years, and with some evidence, it was clear that it is not necessary to supplement glutamine to each and every patient. We know that it has got some physiological role. It helps in transport of nitrogen between the cells and organs, interacts as a metabolic fuel in rapidly proliferating cells. But still, there is no recommendation that it should be a routine supplementation for all patients. And whatever diet we are giving, if we are able to achieve the normal glutamine recommendations which are recommended on a daily basis, then there is no need to go for any additional glutamine supplementation from outside. And some endogenous glutamine synthesis also takes place, and this is what we have to take into consideration, especially the skeletal muscles and the liver. So it is recommended that if you give too much of glutamine, it has been found that it can interfere with encephalopathy, especially in patients with liver failure or who are likely to suffer from liver failure during the IC course. So it is recommended that as far as glutamine is concerned, not a routine supplementation. If you are giving your routine needs, nutrition needs, it has enough glutamine to meet the daily needs of the patients. Yes, as far as the levels are concerned, it has been seen in some studies which have tried to measure. They have found that the levels are low, and it is somewhat like a U-shaped association. There is sometimes like a U-shaped association between the glutamine levels and the overall outcome. So it may be normal, then it drops, and then it starts to pick up. That's a U-shaped curve. But there are some like evidence which have suggested that there is no advantage of glutamine as far as the infections are concerned. And even those patients who have, there is no benefit with bacteremia or the overall outcome as far as the secondary outcomes of isostay are concerned. But there is some population of patients which show that there may be some benefit with glutamine, especially in those patients who are in a high state of catabolism, like patients with burns, polytrauma. This is one population where you might think of going beyond the physiological needs of glutamine. Burns, you may go for extra glutamine. Critically ill trauma patients, polytrauma patients, complicated wound healing, you might consider of giving excess dose of going the extra supplementation of glutamine for 10 to 15 days. High protein enteral nutrition enriched with other immunomodulating nutrients versus the standard high protein enteral nutrition. So what is the role of adding immunomodulator agents for ICU patients? Now, there is a multi-center randomized control trial, 301 patients, and they concluded that there is no benefit of immunomodulating high protein nutrition as compared to the standard nutrition. And they suggested that it may be harmful. And when they found and did a statistical analysis for the adjusted mortality at 6 months, and they do not recommend, do not support the use of immunomodulating nutrition therapy. Omega fatty acids, yes, they had come in a big role in the 90s and 2000s, and they were used like whenever the patient is in a straight high inflammatory condition, you should try to use omega fatty acids. In fact, some studies also recommended, some observational studies, that omega fatty acids can be used in inflammatory conditions like moderate to severe ARDS. But then over a period of time, people started understanding that they are of no use, they are not of any benefit, and they may add to the the possible harmful effects. So what they were seeing that there are several trials, the Redox trial, the Aden Omega Signet, you can go through these trials, and they have suggested that they should not be given, high dose omega-3 enriched formulas are not to be given on a routine basis to ICU patients. You can select some patient where they might have some benefit, but as a routine prescription, it is not to be given for ICU patients. The use of parenteral micronutrients and antioxidants in critical illness. Now we know that whenever the patients, they suffer from critical illness, there's a lot of oxidant injury, a lot of redox molecules, redox injuries are going on. Antioxidants may or may be useful. Like theoretically, it sounds good, but then it has been found that they are not of any benefit, proven benefit. And the combination of antioxidant micronutrients to reduce the infection, it is seen that yes, they might be useful, but then you have to give it over a prolonged period of time. This is what the RCTs have suggested, that they're not useful if you give them in this. You have to give, first of all, they have to give a very high dose, which may be even 5 to 10 times the recommendations. And then if you have to choose, if you want to choose some micronutrients and antioxidants for the patients, they have to be high dose, and then they have to be given for a prolonged duration, might be even up to 2 weeks. Vitamin D, yes, we know that it's a very pleomorphic molecule which almost influences each and every organ of the patient. So it has been found in ICU patients. It started somewhere in 2000. The first studies that came from the Australia, and then almost every nation started studies on vitamin D. We all know theoretically, and it has been proven also, that almost 80 to 90% of hospitalized patients, they are vitamin D deficient. And there are some randomized trials on vitamin D in critical ill patients, and they found that there was a mortality reduction when compared to placebo. But what the recommendations have come is that you can do a vitamin D measure level. You can measure the level at the time of admission. If the patient is on the lower side, if the patient has low vitamin D levels or low plasma levels, you can supplement a high dose of vitamin D, 5 lakh units at a single dose. And if you feel like, then you can even repeat it on a weekly basis. And whatever normal requirements of vitamin D are to be given for any patient, they should be administered even the same for all ICU patients. Now, coming to some special groups like the obese patients. Now, obese patients form a special group because the calculations becomes a little different. That what is the ideal weight of this patient? What should I do? What should be the carbohydrate intake? Am I overfeeding? Am I underfeeding? What should be the caloric requirement per kg body weight? So these become, the calculation becomes a little dicey, and that is why now if you want to go for an ideal situation, then this is one of the conditions where you would like to go for indirect calorimetry. But then, as I have told you, it is not, availability is an issue and cost is an issue, and it has been used most of the times for research purpose. So what it is recommended is that you should measure the urinary nitrogen losses, or you can do a lean body mass determination of such patients, some select group of patients, morbidly obese patients, using the CT or any other guided tools. And you can, or if nothing is available, even indirect calorimetry is not available, then you can go for an adjusted body weight, and then you can calculate whatever requirement you want to go for any other, like any other patient. There is another special group in ICU which comes like non-intubated patients on an IV, on high oxygen therapy, immediately post-extubation, and the patient has some stridor, or you're worried the patient is on oxygen supplementation, you're worried about aspiration, or the patient has a tracheostomy too, and then you're worried that I may or may not be able to achieve that normal requirements. So the recommendations for this patient group is that first of all, you should try for an oral diet. If you're not able to achieve your targets with the oral nutrition supplements, then that is the time when you start thinking of parenteral or putting a nasogastric tube. And even if by oral and enteral you're not able to achieve your targets, then you may even think of temporary parenteral nutrition. But the target is that in 48 hours, you should try to achieve your targets for these group of patients, whatever nutrition targets you set. Now, in adult critically ill patient with sepsis or with septic shock, does enteral nutrition compared to no nutrition improve the outcome? And outcome is like whether it has an influence on mortality or does it reduce the infections. And it has been found that early and progressive enteral nutrition should be used in septic patients once their hemodynamics have stabilized. So that means when the patient comes to you in septic shock, you started noradrenaline and the patient is still worsening, you're adding vasopressin, that is the time when you should avoid enteral nutrition. But once your hemodynamics become stabilized, or your vasopressors have stabilized, or you're in the process of de-escalating your vasopressors, that is the time immediately you should start thinking of going for enteral nutrition. And still, if you are not able to use the gut for enteral nutrition, then this is also the time when you can think of partial parenteral nutrition or complete parenteral nutrition. So there are some patients who come with surgical complications, either after abdominal surgery or esophageal surgery. Here again, enteral nutrition, the rule is that first choice should always be the enteral followed by parenteral. So if you're not able to feed due to some surgical complications, or if the patient has some anastomotic leak, if the patient has some fistula, or you're not able to go ahead with using the enteral route, then you have to think for parenteral nutrition. Unrepaired anastomotic leak, internal fistulas, external fistulas, or even if you try for distal feeding and you are not able to achieve distal feeding, then enteral nutrition has to be withheld. Otherwise, in all other cases, you have to go for enteral nutrition. And you can, if you're not, it may take some days for you to achieve your targets of enteral nutrition. So for that period, you can tide over with partial parenteral nutrition. Or if you're not able to achieve enteral nutrition and your targets even after 5 to 7 days, then immediately you should start thinking of parenteral nutrition. Head trauma patients, nothing different. Only thing is that the patient should get as early as possible, you should think of enteral nutrition. Now, as far as the sepsis is concerned, of the patient of polytrauma or the patient of AIDs, and they are suffering from hypoxemia, hypercapnia, acidosis, these are all going on with the trauma patients, or any of the patient is on ventilator, on high ventilator supports, or if the patient is in septic shock. As I told you, that if you are not achieved your goals, the acid-base parameters have not settled, your lactates are not settling, your vasopressors are not settling down, then you can think of going for partial parenteral or parenteral nutrition. Otherwise, enteral nutrition should not be delayed. Now, these are some areas where you can delay the enteral nutrition, like patient with active upper GI bleed, patient with overt bowel ischemia, patients with raised abdominal hypertension, like patients have got abdominal compartment syndrome, the abdomen is distended, or even if you have started your enteral nutrition, but the gastric residual volume somewhere around 500 ml over a period of 6 hours, then you can wait for some time, you can add prokinetics, again retrieve the feeds within 6 to 12 hours. So the rule is that yes, enteral nutrition is my first route. If not able to achieve, I go for parenteral nutrition. There are some group of patients where I am not able to start enteral nutrition, I'll go for partial parenteral nutrition. And over a period of days, if I am not able to achieve my targets, I will think of total parenteral nutrition. And low dose central nutrition, yes, in patients sometimes like post cardiac arrest, the patient may go for therapeutic hypothermia and you're increasing the dose after rewarming. So even once the patient is in hypothermia, or the patient comes to you like drowning patient, or the patient is all placed on hypothermia, comes to you with hypothermia, then you can reduce the dose of enteral nutrition in the first 24-48 hours. And when you start the process of rewarming, then you can go up on your enteral nutrition. In patients with acute liver failure, which is acute, immediately life-threatening metabolic derangements, and when the patient has done liver support strategies, or if you're worried about the encephalopathy, these are some of the patients where you can think that yes, I can just have partial enteral nutrition, and if needed, I can supplement with partial parenteral nutrition. Otherwise, all patients, like patient even with one ECMO therapy, traumatic brain injury, stroke, spinal cord injury, patients even with severe acute pancreatitis, if there are no gastric high gastric residual volume, you should go for enteral nutrition. So enteral nutrition is the word for all patients. Patients with abdominal trauma, neuromuscular blocking agents, so they're huge list. So any patient, I would say that rather than just going on reading the list, any patient who comes to ICU, you should consider enteral nutrition beyond 48 hours. Now monitoring, yes, this is also extremely important. If the patient is having dysglycemia, sometimes hyperglycemia, then you should increase the frequency of the glucose monitoring. And if the blood sugar targets, like now we have gone for some liberal glucose monitoring, and rather than going for very intensive glucose monitoring and keeping the sugars less than 140, the target has gone up to 180. So still, if you are not able to maintain your sugars of less than 180, you can think of starting insulin infusion. Every patient should have the monitoring of electrolytes like potassium, magnesium, phosphate, and serum calcium. If the patient suffers from hypophosphatemia, then even the frequency of the monitoring of electrolytes can go up 12 hourly basis, or even up to 6 to 8 hourly basis. And then you have to, your energy supplementation also needs to step up gradually, because then you might think that my patient is suffering from some other symptom like refeeding syndrome. So to conclude, do not forget about feeding. In the first 48 hours, start thinking about the feed. Keep an eye on the nutritional targets. How fast you can achieve it is better for the patient. The time limit for achieving your nutritional targets for ICU patients is usually 5 to 7 days. ICU patients are a heterogeneous group of population. So you cannot follow the guidelines for each and every patient. Sometimes you need to customize your nutrition requirements for patients. These guidelines are good. They are based on current knowledge, they are based on evidence, but yes, you have to follow them from patient to patient. Now, just Dr. Anita, you asked me to prepare 1 or 2 slides on neutropenic.
Neutropenic slides, yeah,
so
yeah.
If you permit me, I can just finish.
Please do that, yes.
Neutropenic diet, like this is just to prevent the cancer infection. So basically, these are for those patients who are on chemotherapy, or those who have undergone some organ transplants and they're receiving chemotherapy, and you must have seen, or you must have encountered that they go on neutropenia, and that becomes a very risk factor for acquiring the serious infections. Now they acquire the serious infections from their own microbiota and foodborne. Now, foodborne is one of the risk factors, and this is what all the clinicians would try to avoid. But then I went into the systematic review and a meta-analysis published in 2019 in the BMJ Supportive and Palliative Care, and they found 6 studies who were eligible for inclusion in this meta-analysis, and they found that there is a global inconsistency in prescription of this routine diet versus the neutropenic diet globally. And there is no proven clinical benefit as of now, based on the studies which are active. And this is what the results, the systematic review and meta-analysis suggests, If you look at bacteremia and fungemia, there is no benefit of the neutropenic diet. If you look at mortality also, there is no benefit. So what these meta-analysis suggests, that you should follow the food hygiene guidelines which have been prescribed by the FDA, rather than going for a neutropenic diet, which is like restricting the fresh fruits and vegetables for this special population where you are worried about neutropenia and neutropenia-acquired infections. Thank you.